difficulties this morning. Last week we did a presentation for our faculty of all the new updates in HealthLink, and then we thought that it would be a good idea to share with the residents and others as well. So the agenda is there's a bunch of things on the next slide that we're going to cover. Number one is open notes. Number two is e-prescribing. Three, of course, is a new workflow that's coming for ambulatory. Also, we have a new workflow for dysplasia tracking that happened with the upgrade last week. Update on video visits and charging as well. Next slide, please. So the open notes, which I think everyone knows about, it went live on November 2nd at VMC. What it is it's a federal law that under the 21st Century Cures Act that started in 2016 under Obamacare. It was the premise behind it was to increase interoperability between electronic medical records and to give patients more ownership of their charts. What happens now is basically all notes are by default visible to patients. And patients always had access to their notes before through HIM. They could always get a release of their records, but now it's easier, especially if they're on my chart, for them to see all of their notes as soon as they're signed. And the law specifies that there are very specific restrictions for why you choose not to share, and the penalties are pretty huge if you are in violation of in terms of not sharing. I think the penalties are up to $1 million. So the law is really to share the notes. Next slide. So just in terms of details, notes from our system prior to November 2nd are not going to be automatically released. Patients can, of course, get them through medical records, but we're just going to be sharing notes going forward after November 2nd. And this applies to all notes, not just physician notes, but nursing notes. Anything that's left in the chart would be visible to the patient. So this is a big change, and some of our staff are unaware. So we've been trying to spread the news to all of them. And then the only exceptions for when notes are not shared are basically if there is a suspicion for real harm to the patient, and that would be a reason why you would not be sharing notes. And as an FYI, for teenagers, notes for up to 17 years old, their notes are not shared as a default, but after they turn 18, all of their notes retroactively will be visible. The idea was that since a lot of them have proxies and we didn't want their parents necessarily to have the wrong people to have access, those are not shared. Next. So you may have noticed in the notes activity, there's a button, there's a link on the top right, and the default is supposed to be that notes are shared. You can click the button to unshare a note, but then you won't be allowed to sign your note unless you specify the reason that you're not sharing the note. And there are a couple of there's a smart text that says, like, it's do not share or reason for not sharing, that tells you the reason, that makes you say what is your rationale for not sharing. And ambulatory and inpatient works a little bit differently. The ambulatory notes basically cannot be signed until you specify the reason for not sharing, if you've chosen not to share. And then the inpatient notes, you get a message into your in-basket saying that you didn't share. And compliance will be monitoring this. I believe the fines don't actually start going into effect until April of next year. So we have a little time to get used to it, but the default would be to get used to this this process. Next slide. The how to unshare notes. So when you click that button that's in the upper right of the note, when you click the unshare, then this is the smart phrase that I was saying that you could use, reason for not sharing. And then the only legal reasons for not sharing is because you think that the release of a note will cause physical harm. And Dr. Isquick asked last week at our meeting if that means that, like, if she thought that her patient would commit suicide or do something like that, then that potentially is a legitimate reason to not share. Next slide. So this, a lot of questions came from the faculty about what to include in notes and how to write notes. I think we're not writing notes for the patients, but we just to be cognizant of the fact that when they read their notes, they may have questions. So one of the things that a project that the department's going to undertake is to clean up our note templates. Dr. Dagdag volunteered to represent the residents, and any residents who want to join are welcome to join our little subgroup. But what we are going to do is try to take out a lot of things that are not necessarily relevant to the visits. So we're going to look forward to cleaning up our H&P notes and our discharge summaries and all our progress notes, because a lot of times we use a lot of links to pull things in that may not be relevant to the visit, and that just is room to generate questions. Also, because the EMR makes it easy to copy forward notes and to just to pull in the problem list overview, a lot of that information is not necessarily relevant, and it might be inaccurate because it's old. So to try to be cognizant when you're writing your notes too, or maybe your own note templates for clinic, that you don't need to be pulling in all that stuff, because it'll just generate questions and confusion sometimes. I did get a request from the pediatricians for us not to pull in the whole problem list overview with all the details of prior 5150s and things, because it's sensitive and generates issues. So it's a process that we'll go forward and try to clean up our notes as much as we can. And later at the end, I'll just touch on charging and billing. It used to be that your billing charges related to how many review systems and how many systems were covered and how much of the history was reviewed. Going forward, as of January 2021, that will no longer be true. So you don't need to pull in all that stuff into your notes to be able to bill. Next slide. Yes, and then just some tips for writing open notes is like to be succinct and just to stick to today's problems. And then, as we said, like, don't pull in necessarily all of the old stuff, or be careful when you copy forward that all the stuff that you're pulling is relevant to today's visit. And then Dr. McClellan says she likes .diag med because it's just referring to today's visit and diagnoses. Next slide. Can you go to the next one, Laura? Thank you. Yeah, and then this is the hard part too, is a lot of our docs are saying, well, we're not writing notes for the patients. So I think you're not writing notes for the patient, but just sometimes there may be abbreviations that they don't understand, and it may generate questions. So there are some suggestions, they're all over the internet, about what terminology to use in notes for patients who will be looking at their notes. And then we also have a feature in HealthLink that I can share with you all if you don't have it. It's called the HealthLink User Dictionary, which basically, when you type in the abbreviation, the full words will show up. So like when I type in AROM, like artificial rupture membranes shows up in the note. So you don't have to type it every time, but then it takes out all the abbreviations. Next slide. Resident notes are available to patients once the attending signs the notes. So the attendings should be reading the resident notes fairly carefully and editing before they get released. And med students, when they chart in the med student section, that's actually not part of the chart, which is good in some ways because they can practice, but then that part it's not released to patients. Yes, and then in truth, this open notes thing has caused a lot of consternation for a lot of the docs, but there aren't, other institutions have not reported that many problems. Next slide. And then just so you know, labs, so the law has moved forward to releasing pretty much everything to patients. So their labs, their x-rays, notes. And so you'll notice on the lab orders now, or you might notice that the default is immediate release to patient. So just so you know, the patient may see their result before you have a time to reach the patient. The one difference is if you feel that you need to change and would like to not release immediately, you can change the 2-week, there's a button there that says 2-week delay to discuss with patient. So if you really want to be able to see the result first, that's how you can change it. But then it will be released to the patient after 2 weeks. The labs that are not immediate release to patients are HIV, hepatitis, and PATH. So all of those ones have a 2-week delay so that it gives us time to talk to a patient before the lab is released. Next slide. E-prescribing of controlled substances will become the law in January 1st of 2021. And we know the residents haven't gone Imprivata, and we're working on it because it affects the workflow. For the attendings, I think most of us have it. It's so great. You don't need the prescription pad anymore for narcotics. And then eventually, we have a year until California law mandates that all prescriptions are sent electronically. So we're working on getting rid of all the prescription pads, but January 1st is when Medicare mandates that narcotics are sent electronically. And Dr. Hua is working on this actively to get residents access. Next slide. Next week, we're going to have a new workflow for ambulatory. So there's 2 things. One is at the beginning of the clinic, the HSRs have been arriving all phone visits and video visits. The problem with that is that sometimes we don't get a hold of the patient, and then we have open visits that billing has had a hard time discerning if patients were seen or not seen, even though we don't put a charge on these visits that we don't call. So starting on next week, November 17th, instead of the HSR arriving them, we will arrive them ourselves. So when we're ready, the workflow will be, we contact the patient, and once we've made contact with the patient, you can start the visit and arrive. There will be an arrive button. It'll be pretty straightforward. I'll send out tip sheets. But that will be the new workflow, that you arrive them when you're ready to start the visit. And then there is also a new no-show activity. When you see if a patient no-shows, there's a no-show list. I'll also send you the tip sheets for that. But on the no-show list, you can document what you want the follow-up to be. So you can write patient contacted or not contacted ×3 and plan for follow-up. Next slide. Oh, sorry, here's the no-show documentation. So on the schedule toolbar, there's that X no-show, a no-show list. And when you open that no-show, when you click on that, you can document what your action was, that you called the patient, that there was no answer. You can put comments in, and then this will be stored on the patient's encounter. So you don't have to open a telephone encounter just to say that the patient didn't show. You would just put it on the no-show documentation, and that gets recorded in the chart. Next slide. And now, as of last Monday as well, there is a new pap smear or cervical dysplasia tracking system. This sort of went live without my knowing last week after we talked about it for a year pre-COVID, and then it went live. In theory, it's a great idea when you have a patient that needs to be tracked for some reason. At the bottom of the pap smear results or the tissue exam result, I highlighted down there that link. It says liquid-based pap smear screening. And the idea is that when you open the link and fill it out, two things happen. Number one, it automatically updates healthcare maintenance for what patient is due for. And number two, it's an automatic message to Sherry Kennedy and the dysplasia report. And so it'll pull up which patients need to be tracked. So the tracking form is accessible via links in the bottom of the path reports. And it also will be available through Storyboard through a cervical cancer screening link. Next slide. So when you hit that link, you see the pop-up on the right there that where you can enter what the follow-up plan is. You can say whatever, colposcopy or PAP, and then you put when it's due. So then when you do that, that again will show up in Sherry's list. And then you no longer have to email Sherry or tell her, what your plan is, because she'll get this in a report. If it's a dysplasia tracking thing, after you put what the plan is and when it's due, you put in progress. If it's a normal pap smear and the patient doesn't need tracking, you don't have to do anything, just leave it. And then the automatic default would be 3 years. But if you want something that's not in 3 years, then you need to fill out the form. Just as a reminder, the tracking form does not update the problem list. So if it's a CIN3, you have to put the problem separately in the problem list, nor does it tell the patient about her results. So if your custom is to call or to send a message via My Health Online, it would be good to do that as well. Of course, if she's on My Health Online, she'll see her result in 2 weeks as a default release, but just so you know, that's the way the system's going to work. Also, healthcare maintenance, if those of you who used to use it to fill out the intervals and track patients, that will basically be replaced for pap smears with this new system. Next slide. And then there's just FYI, we have a video visit improvement project ongoing at VMC. The idea is that the bottom line is phone visits and video visits. During COVID, phone at FQ sites is paid the same as an in-person visit. But usually a phone visit is paid much less than a video visit. So the incentive will be to have in-person visits. Because A, patients tend to enjoy them more than the phone, and then B, they will probably reimburse more. So just so that residents are aware through the so sorry, can you hear me now? Okay, sorry, Sophia, thank you for the update. So the video visits are, so the video visit improvement project is ongoing, and they're much easier to do now. Patient just has to have My Health Online, and the doctor just has to have Haiku. So through Haiku, it'll work. going to look at the desktops and if in installing equipment onto the desktops if people are interested in doing more video visits. Next slide. And then the way it works for those of you who are interested in doing them, the same thing, 3 days before your visit, 3 days before your clinic, you look through the schedule and see if you want patients to have phone visit or video visit. And then you could designate in your appointment notes that you want the patient to have a video visit. And then the staff typically calls all the patients 2 days before the visit. So that's why you need to review your schedule 3 days in advance. And then one day, it says here 1 day before. At Baskin, we call them 2 days before. And then the way this is supposed to work is when the provider's ready, the staff will get the patient ready to join the video visit. And then conduct the visit. So if any of you are interested in doing this, let me know and I can try to help you. Next slide. Again, it's telephone visits. The reason why OB-Gyn hasn't really embraced this, that telephone visits are easier. And it was really hard when we first started visits in May because the patients had to have 2 apps. They had to have My Health Online and Video Connect. It was quite cumbersome, but now it's actually much easier because the patient just needs My Health Online. They launch it and it says start visit. It's pretty easy for the savvy patient. Next slide. And yeah, as I mentioned, it can be a little bit challenging for the patient sometimes, but especially for some of our patients who are not video savvy, but overall for the right patient, it works really well. And Kaiser does a lot of these visits. Next slide. So yes, again, if you want to do it, let me know. Sharon in MFM loves video visits also because she used to work at Kaiser. So she is used to doing this. And they did a survey of patients where patients do feel like they enjoy it more when they can actually interact and see their doctor. And then this is probably the wave of the future because unfortunately COVID will be around, it sounds like, for a while. And so we might just have to figure out how to work with it. And then in terms of reimbursement, phone visits are probably not going to, they're not probably going to keep reimbursing us for phone visits as in lieu of in-person. Next slide. And then Sophia says, how does interpretation work for video? Yeah, that is a hard one because you have to you can't do interpretation with video. You have to use the Sericom separately. So that is a challenge. I will get you more details about that, Sophia. And then billing and charging, as I mentioned, residents, I know you don't really bill right now, but you will eventually, just so you know, it's evolved. This is more of an attending thing, but the phone visits now and video visits currently through the end of December can be charged the same way as we charge an in-person visit. And that's because of the COVID pandemic. So we charge them and then with an N95 modifier. And then at FQ sites, which all our clinics are, but not VSC, they get reimbursed pretty much the same as in-person visits. And then starting on January 1st, there's a whole new change from CMS coming for billing. As I mentioned, it will no longer be looking at how many review systems and how many things are in the physical exam. They're going to be looking at time and medical decision making. So that's just so you know. Next slide. And I think that's the end. So does anyone have questions? And
thanks so much, Cheryl. That was helpful.
Yeah. Thank you.
Thank you. And I was recording this, so I will try to share this on either the YouTube or the OneNote so that anybody who needs to go back and refer to it can. Also, Cheryl, if you wouldn't mind sharing your, oh wait, I have the slides. Presentation. I'll try to put the actual slides.
Okay.
So if people prefer, instead of listening, if they want to,
Just read through them.
yeah, do it themselves. All right. Thanks.
Okay,
everyone.
great. Have a good day, guys. Sorry for the
Thanks.
technical difficulty. Thank you.
I'll see you guys all at PAC conference on Microsoft Teams.